Hello everybody, today I'm going to talk about our paper Embodied Negotiations, Practices and Experiences Interacting with Pregnancy Care Infrastructures in South India. I'm Nervo Verdezoto from Cardiff University, and this is work together with Naveen Bagalkot, who couldn't be here, and this is also work together with Syeda, Nicola, Paula, Swati, Deirdre and Judith, and this project is funded by the Medical Research Council. So to start with the motivation, CCW and ACI research has explored the use of information communication technology before, during, and after pregnancy, especially focusing on digital motherhood. There is a growing interest to understand the lived experiences of pregnancy, including pregnancy complications and the challenges women face while interacting with pregnancy care infrastructures. However, there is limited research understanding the bodily experiences and negotiation, especially in the Global South. When we are talking about the experience of pregnancies and reproductions, these are socially and culturally constructed, right? Going beyond the biological changes in women's bodies. Women's experiences of pregnancies are embodied and negotiated by constantly learning, adapting, and performing the daily practices of care for their bodies. And of course, these are shaped by the socio-cultural context. When we're talking about pregnancy care infrastructure, sometimes infrastructure is being considered only as a physical thing, but we are referring to this into a more highly relational concept, right? Looking into Starr and Rotley, that infrastructure is something that emerges for people in practice connected to activities and structures. So rather than looking at infrastructure as a physical thing, we look at it into a more relational concept, right? There is a lot of CSCW and ACI research in healthcare, looking at healthcare infrastructure, but mostly on the clinical settings, right? So looking into the social and material arrangements of people's routines, artifacts, and the visible and invisible work to support healthcare work practices. However, there is care infrastructure also extend outside the clinic into the home, the municipality care settings, and community health settings. So we started our project, the Healthy Crossroad in Pregnancy Care, between the UK and India. This is a paper from India ACI when we at the beginning have different workshops just to understand the pregnancy care challenges in India. And we realized that we need to understand the role of physical of the pregnancy care infrastructures in how they influence pregnancy care. So we started a case study to see what are the relationship and how the pregnancy care infrastructure interact with pregnancy care. So we started a study in rural and semi-urban areas of Channapatna town, located in the Ramanada district that belongs to the Karnataka state, which is the India's largest state. And we reached out 5 rural areas and 5 semi-urban areas with the help of our local collaborator, Maya Health. So I'm not going to explain the whole participatory recruitment, but at the end we have 27 semi-structured household interviews across 5 rural areas and 5 semi-urban areas. So we also invited a number of community health workers also to participate, and we use this data, secondary data, because it has been also published just a focus group with in the previous CSCW paper. And as you can see, this is the review and analysis. We have different workshops, and we come back to the participants, community health workers, and also pregnant women to when we were doing the analysis. So some of the methods that we use were the sketching in a day life, in which we asked to just talk about what happened during the day, and also the pregnancy journey. Just they can talk about and reflect about the different pregnancies they have, and who are the people they communicate to, where do they go if they need help, and what sort of food they are eating as well, what sort of challenges. So some of the findings that we have, it was the disembodied knowing about the responding to changing bodies, nurturing the pregnant body, negotiating the spatial dimension of healthcare facilities, and negotiating when and which healthcare facility to access. I'm not going to go through all of them, but I'm going to introduce the case of Seema, which explore the negotiation that takes place between the spatial dimensions of healthcare facilities. So Seema was 7 months pregnant during the interview, and this was her 3rd pregnancy. Well, her first pregnancy was 8 years back, which ended in a stillbirth at the 8th month. The second one was successful, and she has a 3-year-old daughter. When Seema began vomiting and stopped menstruating, she walked to the PHC, which is about 1.5 kilometers away, and her pregnancy was confirmed. However, she was also severely anemic with hemoglobin level at 4 and was referred to the THC for a follow-up. The local ASHA worker took her and her husband to the THC about 9 kilometers away in an tuk-tuk, where the doctor suggested her to get a blood transfusion at the district hospital in Manja, which is 40 kilometers away. She went there by public transportation with her husband, where she was administered 2 pints of blood over 6 days. After the blood transfusion, her hemoglobin levels rose to 9, but dropped back to 7 within a month. The doctor at the THC suggested her to go for a blood tube, which is applying of red blood cells through IV transfusion, which was performed at the THC. After this procedure, though unconnected, her blood sugar levels also rose during the periodic test at the THC. Seema was asked to consult a diabetologist at the THC, who recommended initially to control her blood sugar through the diet and exercise, and subsequent tests revealed her high sugar levels, and she consulted a private diabetologist in Chanapagna, 1 kilometer away from the THC, who put her then into an insulin dose and recommended her weekly blood test at his clinic. Now, in the 7th month of pregnancy, she goes to the THC. After meeting with the doctor, she goes to the private clinic to get to the blood test done. Then she gets back to the THC to get all the reports and come back home after a hectic day long trip in a tuk-tuk. Seema has to visit also the private lab in Ramanagara for the ultrasound scans once every 2 months. This involves a lot of work, physical, but also emotional and social work that she has to perform almost on a weekly basis, while trying to navigate and negotiate across the different elements of the healthcare systems. So this is just one of the cases. Then the other one is negotiating norm and access to critical care in time. So beliefs arising from traditions also interfere with the delivery of care, such as, for example, one should not give birth at 9, regardless of the pain a woman might suffer through the night, and go to the doctor only in the morning, adhering to the same beliefs of her family as they lack embodied knowledge. Then this lead to a negative embodied experience for Seema because she has a stillbirth during her first pregnancy, as they waited until the morning to visit the PSC. So there are many different opportunities to design to support the embodied experiences with pregnancy care infrastructure. So the first one will be to account and support peer-to-peer local solidarity networks. The second one could be supporting local forms of knowledge and knowing, like, for example, trying to create a local health knowledge repository, or trying to create a know-how tool that can support and provide available situating information to help the pregnant woman to navigate. So thank you very much. This project has been funded by the Medical Research Council, and if there is any question, probably we can take it during the conference.